Okay, everyone. And you see that what we're talking about today is the implications of AI in forensic and clinical practice. So we're starting with some basic definitions, and that is AI isn't really intelligence. It's logarithms that gather information, and it could gather it rather effectively. I'm very involved in K through 12 education. And I just was at some presentations to hear what districts are doing with compiling data. And uh, there's something called Google Notebook, a lot of different ways in which AI is being used in classrooms. But today, what we're going to talk about is forensic and clinical practice. So let's move ahead and to the next slide. See, it should click. Okay, here we go. So this is the outline. One is how are clients using AI? And clients go across the board here, right? There are clients that are attorneys. There are clients that we're seeing in psychotherapy because this is both clinical and forensic. What are the challenges that we face? It's really changed the way forensics work because what it's done is attorneys are taught that you never ask a question that you don't know the answer to, because then an expert could take advantage of your lack of information and supply things that could influence the perceptions of the trier of fact. We use the term trier of fact to represent either the people who are administratively hearing the case, whether it's the Queen's Bench or whether it's a jury in the United States. Then we're going to talk a little bit about information about therapeutic approaches, how that's coming in, how that's influencing people, how apps and other artificial intelligence are augmenting treatment, information on assessments and how that's coming in, and the opportunities that we have in terms of using AI, in terms of the aggregation of data, and changing some of the normative-based ways we used to approach the gathering of normative data for comparison. Also, there's issues with the ethical and acceptable use. So one of the things we look at is the teaching of young people about cyber citizenship. How do you incorporate that? What are ethical uses? You'll find in different codes for different professions that many of them now are including sections on computer, internet usage of devices, because we're finding these devices are used often in the broadcasting of intent, in the studying to get ready for acts of crime, very central in the area of threat assessment. And we'll talk about that. Then finally, we'll come to some conclusions. What does all of this mean? And that's how we'll progress here. Looking for my arrow. So for some people, there was concern with the use of the chatbots, where that potentially they had the ability to replace low-level complaints that someone was having in their existence about their life. And so that then becomes an issue. However, what we're finding is that potentially information and the consolidation of information and the gathering of information can be augmented through AI. But what's the most important element in health is connection. In England, they have a minister of loneliness, and they have a hotline for that. They also have that in Japan, recognizing that the cost of isolation is highly significant. Our Surgeon General's report before the current one, Vitek Murthy, who also wrote a book on loneliness, following in the footsteps of John Cacioppo, who wrote an important book about loneliness, finds that if you are isolated and lonely, it's equivalent to smoking 12 to 15 cigarettes a day, that it has implications on health. So if you have health coverage like you have in England and elsewhere in the world that is provided by the government, if you're able to deal with the impact of isolation, you're able to dramatically reduce healthcare costs. The other issue where this comes up is in terms of what we call regulatory theories that we now, and I'm not talking about agencies and the like, I'm talking about dysregulation and regulations of emotions and affective states. We need a relationship for that, and we need a connection. And AI's ability to emotionally respond in a manner in which a connection is made is not very enduring or long-standing. So the initial emphasis on chatbots stem from the fact that there are not enough mental health people to assist either forensically or clinically, not enough psychiatrists. At one point, there were just 2 psychiatrists in Nigeria. There's shortages around the world. And the idea was, or people are rural and they're spread out. So the concept behind a chatbot to have this as a potential therapist was you can't get in for months, sometimes to see a psychiatrist in various areas in the States. Some countries, it's almost impossible to get in due to shortages, or you don't have the funds to get in. And here, if you use a chatbot, it could substitute. The other issue became one of after hours. Often people have crises and it's not during the normal working day. Could be late in the evening when most people are sleeping. And a chatbot was something you could talk to after hours. The other possibility in terms of assistance is that AI, or how information is gathered or shared, can be used for skills building and by having you focus. So if you look at many of the apps that are available today to augment therapy, they will have mindfulness exercises in them. They'll have relaxation exercises in them. They'll also provide information about charting. So here, the use of programs and AI in those programs helps remind you to take medication, to meditate, and can be incorporated with other devices such as smart watches and other things that can determine that you're not sleeping well, that you're having problems. That shows that you're becoming dysregulated or you're decompensating, and then you could build that in. One of the apps that I just referred to yesterday in a training I was doing is the Virtual Hope Chest, and that's by the Department of Defense in the United States. And that's the concept in depression, if someone's suicidal, that they have a place where they put their hopes and dreams. So one of the things that could happen is that information could be gathered regarding affirmations, expressions of gratitude, those types of things, which could be very helpful for therapy. And in that way, these devices can be one of assistance rather than one of competition or replacement of people who do therapy. And you heard in the last webinar uh, that the view is that therapists will not be replaced. And when I speak to teachers and other people, because the conduit of change is the therapeutic alliance, the type of alliance you could have with a real person is very different. So that becomes important. So this is an example of the Virtual Hope Box, and there are many different levels to it, and you just download it on your phone. And again, as you could tell, this is from the Department of Defense, because they were dealing with suicidality in such great numbers that it would create problems in terms of people needing to have something to intervene, and there would be a chat bot, and there would be that opportunity. Let me chat. Okay. So, in terms of these types of applications, I end up providing this sometimes to veterans, and there's also PTSD coach and a number of other ones. So let's move on. Let's go down and click. All right. These are recent articles. And are our skills irreplaceable? Uh, the relationship cannot be replaced. That's irreplaceable. But again, here's the concept of we need to have thoughtful and strategic implementation of AI. And I'll talk a little bit about that as we move through. But let's get back to this concept of mental health bots. So there's this organization which initially came up with a app called Woebot, right? Woe is me is there's cleverness in this name, means that someone is suffering and having a hard time. So if someone's in a state of woe, this very concept of there's something that could help you deal with this. So the issue was they ended up programming something using therapists. And if you go to their webpage, you'll see they have a lot of talent behind this. And they'd come up with rules. These are the algorithms that then help this. And then evidence-based responses. So you had clinicians, you had writers, and you ended up with, for example, if a patient was having an argument with a family member, you have what's at the bottom here. Rather than having something that reads like a formula, that sounds like a relationship problem, Woebot responded with true empathy. Now, I would say that if it's a canned statement that comes from AI, that's not the empathy we're looking for, which is almost a heart-to-heart resonance with someone. So this was considered to be true empathy, which was family situations can be hard, especially at this time of year. And any of you who've worked with clients know that if they hear anything from you that sounds like it's canned and not genuine, you've ended up losing out on what's going on. The slides will be available. There's the link to go to the Woebot, see who's involved with it. And Dr. Allison Darcy, who created Woebot, and she was a researcher and put together this incredible team, was seen as one of the top 100 people in the world and as an influencer in the lot. And this seemed like a great idea. And then you had this, as you see, World's Best Digital Health magazine talks about mental health doesn't needs have multiplied, support hasn't. Let's get together with chatbots. And too often people don't feel supported, so do it with chatbots. We do know that long-term outcomes in therapy are best sustained when a therapist will check into someone after they're terminated, that relationship continues to function. I'm not going to show this, but there are different YouTube discussions of the values of various chatbots. So that's available to you, and that's why that's in the slide below. Now, what happened was, because of the backlash and pushback and liability issues, chatbot was then shut down in terms of an app. However, within a month or so, it was up, they moving away from direct to consumer and app model. They now see it as something to incorporate within healthcare systems. So although the app was retired, there now is the ability to have this to augment treatment. So Woebot Health is not gone, and you could basically go there. So let me go backwards for a moment because I clicked ahead of myself. I'll do this. Go back. And so let's talk about what are the opportunities here. The opportunities with AI are to augment treatment. So some people have things available. Incorporate apps in treatment, like I showed you, Virtual Hope, and there's others that could be used that we use. Have someone while they're waiting to assess things. And you use it as a toolkit to empower someone, but you recognize it's a tool, it doesn't substitute for you. Now, I was involved in a company that shut down as an advisor called Bridget. The concept of Bridget was a positive, number one, a conglomerator of information that if you were a student in school that was having difficulty, you could go online and find something about being teased if you're overweight. You could find inspirational songs, all these different types of things. But the main issue was a platform that would keep lists of things that were going right in a school, and ways to compliment classmates. And the concept here was that if a child wasn't getting any compliments, that meant they're more isolated and there could be more problems. And so that aggregation of data, the ability to find someone, was what we created with Bridget. I understand from its founder that it's going to be started up again, but it ended up closing down during COVID, despite being in schools in Miami and California and in New York, in part because the revenue it needed to generate after all the developmental costs was so great, it wasn't able to sustain itself when schools weren't using it for a period of time. I mentioned the virtual hope box. So what are the challenges? Some of the challenges exist if we have someone engaged in too many treatments. And that is, they may hear different things from different treatments. And we refer to the sine qua non of borderline personality as splitting, in terms of how someone will see someone as all good and all bad. And sometimes the problem with what's online is it can undermine medical, psychological, and other things someone is trying to accomplish in the world by giving advice that may not be relevant to the situation or will confuse someone. So that's that concept of too many cooks in the kitchen. It's also tenuous. It isn't a real relationship in terms of the fostered help. It may only be there while someone is there, and making it more tenuous. Again, if we look at relationships and connection as one of the best responses and predictors of outcomes to adverse childhood experiences, you're not going to have the same impact. Many of you remember Harlow's study with the cloth monkey versus the wired monkey. And the real issue was it doesn't matter if food and basic needs are provided, you have something that complements you. There's a need for that connection, for that intimacy. And that connection is often lost through something which is more based on algorithms and formulas. Further, there could be a lack of awareness of what's going on because an algorithm is going to be cued by a statement. It may attempt to get more information, but there could be problems when you look at a complete understanding of what might be happening. And that lack of awareness can create difficulties for effective interventions. Here's a good example. Here's a teen who used ChatGPT, and he used it as a friend he confided in. And this is from an article in the New York Times, which is easy for you to discover. You could tell I do forensic psychology. I'm using discoverable, like discovery forensically. So this looks like a nice young man. You could see a picture of Adam Rain, and he ended his own life. And the issue of how do you respond to suicidal ideation, it's the same issue in threats. Thousands of threats are made. They could be an expression of pain, of anguish to get someone's attention. How do you determine if there's an imminent risk is something that we have not built into our AI. And empathic statements, or you should contact someone, or those other statements don't necessarily help. Here's an example of, we talk about AI psychosis, making up sources, uh, basing it on something it said before, because now that it provided that answer, it has it in its stock kits of ways to do things. And this concept of AI psychosis, where it makes up things, can become an issue, or it could tell people things which are not very helpful in and of themselves. Uh, there is a sense, and this could be the curmudgeons among us or the people who are technologically phobic, is the therapists have to battle AI, that it poses a risk. And this is from Ellen Berry, March 1st, 2025. And the issue is, how do we take this in? I know, for example, in terms of the AI search engines, there are now guidelines in terms of putting together presentations. And we'll talk a little bit about that as we approach the potential ethical issues. So again, when AI is offered as a substitute for therapists, there's something that can't be accomplished, which requires that relationship. Here's an article from the psychiatry side of the house. And the word used frequently is the word iatrogenic in medicine, and that is when the cure causes other problems. So we have this confluence of people are so much more comfortable on their devices that sometimes it becomes the way to connect with people. They're not able to have direct conversations. This became aware years ago when I was doing a presentation on how, and this was due to research on internet usage, that there was now a increase in erectile dysfunction in young adolescents, boys never seen before, because the only thing that was stimulating to them was being online. The World Health Organization added internet addiction disorder to its diagnosis. And you want to meet your audience where they're at. And we have a lot of people who they're endlessly on their devices. And so the issue was chatbots were created to use AI to help look at threats and the like. But what we're finding is it doesn't work with very vulnerable populations that need someone to be more proactive than just give words. Now, some of you may remember Eliza from years ago, Eliza, and that was a done with a mega computer before computers got small at UCLA, and they programmed a computer to respond similar to Dr. Rogers, who had interpersonal therapy and worked on being affirming. So whatever someone said, it was affirming. That was really our first AI response to treatment. So again, because there's a lack of mental health people need something. There is an attempt to use AI. However, you saw that there are harmful incidents where people have been supported in their delusional beliefs and sometimes encouraged to engage in self-harm, and then that becomes an issue. And so much so that there has been hearings. This is the father of the young man you saw who took his life. And you have someone else who is sounding the alarm of this lack of proper response. We also know that someone could be in therapy and commit suicide, and the highest risk of suicide is when someone's discharged from a treatment facility and someone falls through the cracks. So it isn't like therapists will always be perfect. And we also know that in forensic assessment on dangerousness, there are factors in someone's life that we can't necessarily predict the same way. Now, the real issue with AI is where are they getting the sources? Garbage in, garbage out. The AI hallucinations we talked about. Sometimes there's false information. There could be bad suggestions of what someone does. Uh, Often what's online can fuel comparisons, and comparisons are toxic in relationships. They're not connection. Comparisons isolate us. It could lead to intellectualization. Also, diminished involvement in the world because you're spending more time at devices rather than meeting people or getting involved in the groups or the socialization practices that deal with the risk factor of loneliness. It's also a place of justifications. For many years, there were Annie sites, which were for anorexics that would tell them they were too fat when there's a high risk of suicide and death related to anorexia. Justifications get incorporated through the logarithms in multimedia, where if you're looking at something, and I saw this during COVID, about vaccines containing nanobots, pretty soon you'll get all those articles on that subject that deal with issues of things like nanobots, and that then makes that more real. The other issue I've run into is that sometimes people in treatment will read how the treatment should be done and challenge what you're doing. If you look myself up online, I probably have 20, 25 pages now in Google just in terms of back history. You will find things that, I just Googled myself before the presentation. It lists me as an associate professor. That was 15 years ago. I'm a professor emeritus. You'll find things which are not up to date and not true. And this information is being used when someone's looking for a therapist. So, what about using ChatGPT forensically or clinically? And what I did was I did some searches to show you. Uh, and what I did was I typed in, tell me about the MMPI, since it's widely given, the structured interview of malingered symptoms, or the SIMS, and the word memory test. And so what I basically heard was, it was that these symptom validity tests are used to invalidate your test results. These tests can lead to certain jobs to be disqualified, and they could damage your credibility in clinical or legal situations. This is not usually the informed consent that we give someone in a forensic evaluation. We let them know that it could be used, that we're evaluating, that it's best for them to be honest in the reporting of their symptoms. But we don't tell them we're giving you tests to measure your response style to see whether or not you're not telling the truth. So years ago, we did dissertations on what you could find online and how that could collide with a forensic evaluation. One of the people who did that was a student who Genevieve knows, Tracy Ware, back from the program. The issue becomes one now that ChatGPT or Gemini, any number of these Copilot will pull up information about these procedures, and we have to take this into account when we're doing an assessment. The other thing I found was, and this was on Gemini, was it provided a video overview of all of the scales on the tests if I typed in MMPI 3, and then you could watch this hour and 26-minute class, which provided an overview of the rationale and methods used in the development of the MMPI. All that's available to you relatively easy by using one of these AI search tools. The other thing I looked at, and I mean, this was the query. It dealt with looking at the MMPI 3, the word memory test, and the SIMS. And remember, these are large language models that are incorporated in the AI. And basically, what happens is you have the purpose of the test, the structure of the test, and this is supposed to be non-coaching to test-taking strategy. So I have an MMPI 3. It tells you the length. It tells you the validity scales. It gives you a test-taking strategy, be honest and consistent, which is good. It warns the tests are designed to detect cheating, faking good or bad, so someone can know that ahead of time. So that sort of changes that whole process. I mean, we tell people to be honest. Word memory test, a symptom validity test to detect non-credible performance. Now, the nice thing about the word memory test, if any of you use it, is that it changes the name of the test. So it doesn't read word memory test when you go to take it. And then there's the test-taking strategy. Anti-coaching, it says it's not coaching. Again, do not exaggerate or under-exaggerate symptoms. But that's a different world of going in this AI world and doing a forensic assessment or doing clinical work. The same ability to look up testing you could do to look up treatment. So we didn't have enough time to go over what I found on different treatments, but I looked up emotional focus therapy, EFT. I looked at dialectical behavior therapy. I looked at what they described as good therapy, how your therapist should act, what's involved in it, what are the limitations, whole other pieces that could change what's going on for someone clinically through the use of AI when they're in your sessions. Now, the other issue that comes up is one related to cross-examination. And as I said earlier, usually an attorney will not try to take you on in the area of your expertise because you could easily answer their questions. They don't know if it's correct. They don't know how to challenge you. They don't know where you're going to go. They don't know whether it's going to be helpful or harmful to what they're trying to present. So what I did was I went, and this is what I typed into chat. Cross-examination questions for an expert witness testifying about MMPI-3 in legal settings. And what they came up with was the following, that the goal is to challenge the weight and scope of the expert's opinion, not the test itself, because it's considered empirically valid, but this is the way you go about it. One, you challenge the protocol validity. And we'll have little bubbles moving. These questions examine whether the test met the standardization and whether the examinee's effort was valid. How was this standardized? How was it approached? And ask questions. Did you deviate from it? So, for example, was this test normed by people sitting in a waiting room where other people are present before they go inside? How many people took that? How was the test developed? And this then becomes questions such as, what was the specific physical setting where the test was administered? What was the examinee's attention level, physical comfort, emotional state, documented throughout the 20 to 50-minute administration time? Is suggesting that's standard of practice, that you are writing things while someone's doing it and documenting, or you're remembering them. Is there a cannot say scale, which has been part of the MMPI since the original one? And there's a certain number that if it's over that, it's invalid or not valid. And what you ask about questions of what was left blank then becomes the issue. There are issues with response style and validity. And so they will ask you, and you could imagine this if you're in a civil lawsuit and you're dealing with a plaintiff and you're on the defense side, you could focus on the FP or infrequent psychopathology scale. And this is how it's interpreted, that its elevation could suggest overreporting or exaggerating. So let's look at it this way. They do not have a forensic or clinical psychologist's understanding of what influences someone's response style. Is it after 5 years of no one listening to them, they feel everything needs to have highlighters, so they exaggerate? But now you have an attorney immediately knowing what the FP scale is. Then you go to, what is the impact of any of these elevated validity scales which exist on this test? And then questions you could ask about, how do you know it's genuine psychopathology? And doesn't that mean you need to interpret your results? Conversely, the L scale, uncommon virtues elevated, does that suggest the examinees portraying themselves in over positively light? That's a boilerplate statement in the software if L is elevated. But what also do we know about L? When you study these examinations, you know it could also reflect a certain amount of strong religious beliefs. So people deny certain faults because they have a life where they try to never tell a lie. So they indicate things which are highly improbable, which then claim to be an uncommon virtue, which then elevates the L scale. The software doesn't know it. It only knows the boilerplate statements. And this then helps the attorneys who are challenging you. A scale interpretation. These questions talk about the application of the scales and limitations of computer-generated reports, which in of themselves were a form of AI pulling boilerplate statements based on certain scale score. Is your final diagnostic opinion based solely on computer-generated report? So one of the things we say in forensic evaluations, it's a table that has four legs. That's what we rest items on that table, and then we know that table's firm, and that involves the review of discovery, interview, psychological assessment, and the seeking out of other discovery which are consistent, which could be school records, which could be interviewing important people that know a lot about someone, such as if someone gets their nails done or their hair done, often those people know and have seen what someone's going through. And that could help a defense evaluation, or that could help a plaintiff's evaluation because they know what's going on. None of us should ever rely on computer narrative reports, either clinically or forensically. T-scores. What do T-scores mean? It's a tendency. How well does someone fit in the normative sample? That's true with all of our threat assessment instruments. A lot of them come out of Canada, and the population you may be assessing doesn't necessarily match that. But this is a whole world that has changed dramatically with the ability to pull this up through AI. They could go after you based on what's going on with an AI search in terms of specific references. RC6 is a scale that deals with ideas of persecution. Is this score sufficient to conclude a diagnosis of psychotic disorder? Why was it elevated? Is it merely suspiciousness or distrust? Those of us who've given a lot of evaluations in criminal and civil situations know that when someone endorses an MMPI-2 item, such as people have it in for me or people are saying bad things about me, that happens in the press if there's litigation, it happens in the courtroom, it happens in allegations, it happens in copies of complaints. So some of those things are elevated just by the nature of someone being involved forensically. The issue then becomes, the more we rely on summary data from computers, did you ever look at the raw data? And how did it contribute to the elevated scores, which are the individual test items? And some of the things sometimes people miss is the lack of asking. If someone said, recently I've considered killing myself, have you asked the person about that? And if you haven't done your job, because what's more important is the person's life, not your findings as an expert, or you're incorporating testing in your treatment if you don't use the information that's provided to you to help you connect with the person and help them manage what they're going through. Challenge the appropriateness with populations. That can happen with all of our tests. How does it fit? How does it fit the legal matter? I use the TSI, which is Trauma Symptom Inventory, and I will have challenges about the atypical response scale, because malingering is supposed to be 15, but I'm not looking to determine malingering. That's a multi-factor determined behavior. How has this test been used in your application? For example, we don't use these tests for competency. They're more personality tests, fitness for duty evaluations. How does that fit? What's the job description? What's the demographics? We have a long history of certain tests not fitting certain demographic groups and being prejudicial. For example, the COMPASS is a threat assessment test, and there's been a lot of challenges to the fact that it measures adverse experiences and other events in someone's life in a way that could be prejudicial to someone. So that's an area of what can happen. How do we predict violent behavior? So in forensic use, here's something that talks about it that's available to you through the search I did. This was at the very bottom. These very issues then can be used when you're challenged. So we have to go through, how was the person interviewed? Is it trauma-based? Were they sexually abused in the past? So what I did was I asked the computer to help us with this if I had to do this interview, and it came up with a mind map with these steps. Establish safety. This is how you do it. Body language. Build trust and rapport. Use empowering language. Open-ended questions. Avoid re-traumatization. Validate and support. Clarify next steps. Give options. And this is the mind map, I had actual statements, what the therapist could ask, how the patient could respond. I know law enforcement facilities that are now using AI to train people in interviewing as they pull this together. There's prompts. First disclosure, 22-year-old. Let's say your therapist doing an intake. Roll for the examiner. Establish trust. Avoid rushing to the disclosure. You have to build that first. Validate survivor's courage. Another example, survivor with memory gaps. Is this normative memory confusion? What happens to trauma memory? And you move on. So AI utilization in cyber investigations, another area to look for leakage. It's online. We're using that. My SCSU team, we've looked at daily digital connected life and usage. We look at the NEAL, range of affective experience. Digital information now is incorporated in BTAT, which is behavioral threat assessment teams, and the like. I'm going to begin to wrap up because we only have a few minutes left. But what we're finding in threat assessment is the consumption of certain material and going to certain sites before shootings is something that becomes very important. So forensically in threat assessment, I'm working with law enforcement computer centers, which are around the country in the United States, where we've prioritized going over digital data and looking at behavior. And there's a lot of issues that have helped us in determining what's going on. Someone looking for certain weapons online, someone getting inspiration from other people who've committed crimes, whether in New Zealand or England or in the United States. So AI is increasingly being used in risk prediction. There's problems with the compass in some of these tests, chatbots, lie detection, and there's complex issues. Bias, accountability, how you see people, patient privacy, informed consent, and how it could be misused. Ethical guidelines, good for brainstorming. Again, hallucinations, we verify all sources. Remember plagiarism? Same issues apply to what is suggested to us. A good 80-20 rule is make 80% of what you do your own thoughts and thinking, and only 20%. So it's used for brainstorming. We need to watch for over-reliance on data summaries. We have to be careful with the summaries that treatment notes make, because now there are applications that will do that for you, make sure they're accurate. Don't trust AI. Let it be your starting ground and always verify. There are guidelines in the formulation of presentations. You can now use AI and some programs to create books and pediatric and clinical sections that help your children. Keep all this in your records, your prompts. Always ask the word references when you receive something from AI. It'll give you its sources and then look them up. Keep the results. I use more than one AI generating engine because I know other people may be looking at my work using AI. Here's the difference between clinical and forensic psychology, use of informed consent, and bias. There's compass, which is mentioned, transparency. Where did you get things from? There's issues of social media use. More and more that's happening in personal injury cases. We look to see if someone's behavior is consistent. Here's a comparison of traditional versus AI-enhanced research. The speed is amazing with AI. There's bias that can come through that we could account for clinically. Adaptability, AI changes a lot and changes. Interpretability, AI is not good. We have to incorporate a lot more in our understanding of people. Data integration, more data points could be looked at by AI. And so that basically is the end. These are typing in, asking for references on what I presented from Gemini about AI's use in couples therapy and different treatments. These are references from ChatGPT, part of the slides. And I looked up some of them. I didn't do all of them. I wanted to show you how I asked for references afterwards. And that's it. We're at the end of the hour. Thank you. There was a lot of material today that we went through really quickly. And I appreciate you being here. Okay. Thanks, everyone.